Good evening, everyone. I'd like to welcome everyone to the Ask the Experts week 8 Ask the Expert case discussions. We have some cases today that we'd like to discuss. We have our faculty that we are lucky to have to help us discuss. We have Brett Christ to the other chair. Maurizio Cafori is on, Raphael Neiman, Tim Weber, Mike Miranda, and Jim Standard, and these are the faculty members that will help take us through these cases. Remember, if you have a question, to use the question and answer and not the chat component, and we will do the best we can to answer all of your questions. So the first case was sent in to us from Buenos Aires in Argentina. This is a 32-year-old patient that has a proximal tibial malunion secondary to a medial tibial plateau fracture about 3 years ago. The patient presents with complaints of pain, problems walking, and some varus deformity of their lower extremity. The plan was to do an intra-articular osteotomy with a structural tricortical iliac crest. It's an old case and it was performed in 2012. And they admit that there's no CAT scan or standing x-ray. So at this point, I'd like us to take a look, and will one of the faculty want to comment on what they see here for these x-rays? The image all the way on the right is a contralateral side. Maurizio, do you have some opinion about this?
Hello, Mike. Thanks. So basically, what we see here on the AP view, there is an inclination of the joint line. You can see the medial tibial plateau is very much angled in relationship to the joint line. And if you go to the lateral view, there is a clear impression that there was a posterior medial fragment that ended up healing in an abnormal position with displacement towards posterior and medial. So this is a situation that potentially was a Schatzker type 4, and in the neo classification system, it's a 4P, 4 posterior quadrant. And most likely it was a varus dislocation that happened there and ended up healing with the varus alignment.
Okay. Do any of the other faculty members have any comments relating to this? So let me take you to the next slide that we have here. And so this is being done through Bone Setter. And measuring the appropriate angles on the right side as well as the left side. I'll let you take a quick look, and then one of our faculty can make some comments about the measuring. I do want to point out the nice use of what Raul Veda showed us, which was using this hip center tool, both on the femur here. And this is a good way of just getting the center of the femur here so that you can drop the line down, and doing the same thing with 2 points on a tibia. And then this way very nicely gives you the long axis of both the femur or of the tibia, as well as done on these shorter x-rays on the normal side on the left side.
As a comment to your comment, Michael, I believe it's a great method when you don't have a long leg standing. Two things should be taken into consideration here. Number one, sometimes it's a non-weight bearing situation. And the other thing is that you can get to the anatomical axis. So you should be aware about the normal joint orientation angles in relationship to the anatomical axis, because you don't see the femoral head. So you don't have the femoral mechanical axis in this case.
Maurizio, due to the proximity of the joint line, do the mechanical and anatomic axes, do you feel like there's a big discrepancy down there?
I would say there should be, in this particular case, there should be some discrepancy. I would say Normally there is a natural deviation of 6 degrees or something like that between one and the other. And this is why I'm saying you can use either method as long as you're familiar with the normal values for each one.
Thank you. I agree.
Thank you.
Maurizio, what do you think about these angles? So on the, we have a 76.4 degree angle on the right and 86.9 on the left.
Thank you. So as you can see on the left side, first thing to observe is that the joint is very parallel to the floor, or it's a kind of perpendicular alignment to the floor. And if you look to the right side, the joint line is oblique. And the obliquity here is explained by the reduced MPTA. It's reduced by 10 degrees approximately. The thing about X-rays, they can give you a very interesting visualization of the coronal plane, but they don't give you the three-dimensional understanding of the deformity. You don't see in these pictures where the plane of the deformity is located, but you have a good sense of the varus alignment here.
So Mauricio, when you look at a case like this, and just to follow up on your particular point, you're looking at plane radiographs and you don't happen to have a CT like in this situation. How do you determine whether you're going to do a partial articular osteotomy or osteotomize the entirety of the articular surface, with proximal tibia fragment? How do you decide?
Yeah. Thanks, Michael. Basically, in this case, we have to address the MPTA, which is abnormal. But if you look at the pictures that were presented before, it's clear that this is a joint that looks like very normal on the lateral compartment, and looks very much you'll see an inclination in the medial compartment. So this kind of angular, and you see that the medial tibial plateau looks shorter or not as wide as the lateral tibial plateau. This gives us a sense that this is a kind of unicompartmental deformity, and the lateral view confirms that what happened here is that the medial tibial plateau was displaced, generating an angulation of the joint, which is predominantly in the medial compartment. If you look more proximally on the AP, it looks like that the metaphyseal area is kind of close to what you would expect to see, but there is a very significant tilt of the medial plateau in relationship to the lateral plateau. And you are right, without CT, this kind of assessment is more complicated, but René Marty was one of the individuals that helped me to understand this kind of deformity, because he also described how to address those unicompartmental deformities that are secondary to those kind of fractures.
Mauricio, in a situation like this where a number of the angles are abnormal, especially the 78.48, but we know that there's a displacement of the articular surface, do you try to address both, or get the articular surface right first and then recheck your angles and do a second operation if necessary to address anything metaphyseal?
Thanks for this question, Jim. Basically, you're absolutely correct. What I've seen when it's a unicondylar fracture, like a type 4, that does not cross the midline, it's very rare that you're going to have a malunion that compromises the metaphyseal area. It's mostly a displacement of the articular block. When you have a bicondylar tibial plateau fracture with this kind of deformity on the medial side, most likely you're going to have an intra-articular deformity in association with a metaphyseal deformity, because in this situation, the two condyles of the plateau are dissociated from the metaphyseal area, and the chances of a metaphyseal deformity in association with the intra-articular deformity are very, very much the case. In this case, if you look at the lateral column of the tibia, there is nothing abnormal with the lateral column of the tibia. The lateral cortex is intact. It gives me a sense that most of the deformity is coming from one compartment. But this kind of assessment that you're requesting, exactly where it's pointing out, yes, exactly there. You see, looks very normal to imagine that you have a metaphyseal deformity there. You may have, but it's not typical when you have a unicondylar fracture or unicondylar malunion, because this is the area that's displaced. But in medicine, we don't have never and ever. So it's a good point that you're bringing up, that we have really to make sure that you have a good planning. And this is when CT scans, when available, they can give us a more comprehensive evaluation of the deformity.
Maurizio, when you're planning for a case like this, do you get MRI at all?
Yes, nowadays I have MRIs. And this is something I learned from Jim Stannard. Before working with Jim Stannard, I was used to be based on CT scans only, but he showed me the value of the MRI for those cases. And it's very helpful because it gives me a better understanding about what is going on with the cartilage and what's going on with the soft tissues around, because the X-rays and CTs are going to give us a great sense of what's going on with the bone. But we have to understand, and we have to make sure that we disclose to those patients that even if we can improve the mechanical access, sometimes they have associated injuries to the cartilage, especially in this case, which is 3 years old, that you cannot properly address just by correcting the mechanical access.
Right. In those cases, would you consider unloading the medial side?
Yeah, eventually, yes. But you have to be careful, Mike, because sometimes to unload the medial side in a unicompartmental osteotomy, you may generate, again, an obliquity in the joint line to the other side. So this joint is tilted towards medial, and to overcorrect this one, you're going to generate an obliquity towards lateral. So, and then your medial plateau is going to be higher. And you have to remember that if this patient may need a knee replacement later, this kind of obliquity of the joint line makes the future reconstruction of this joint a little bit more challenging.
Right. And alternatively, you could consider going above the joint line in order to unload it.
Yeah.
Potentially.
Yeah. So to unload this joint, if you want to really do an unloading situation, I would try to correct the deformity at the joint line to the neutral angle, and you can introduce a little bit of correction in the metaphyseal area as well. But again, the risk that you have is that your joint line may become slightly oblique, which is what you try to avoid when you do osteotomies.
Of course.
Okay. I think that was a great discussion on being able to evaluate this. Here's in the operating room. And then here we see the plan for their osteotomy and doing a osteotomy of the medial condyle of the tibia. Looks like some guide wires are placed up, and then using an osteotome to follow the wires so that they get the osteotomy in the correct location. What technique do you like to use for these types of cases, Maurizio, or any of the other faculty?
I think in this situation, I use a similar technique, medial side with I'll use a distractor to unload that area to make sure that it's easy to open up and make the correction. The other thing I think is that I'm particularly delicate with regard to the posterior aspect. Obviously, the neurovascular bundle is back there, and so I use a kerosene rongeur and really work under direct visualization and particularly careful back there.
I would say I agree with Michael. I would like to say that it's important first to understand where the main fracture plane was located originally. So then you can go guided by C-arm and have your K-wires placed exactly following that plane of deformity. Otherwise, you may go to a different plane, and even if you can lift the joint's line, you sometimes cannot really correct the main plane of the deformity. It's easier to go from the front, but in order to do this particular osteotomy, you have to elevate the MCL, and I believe this is what happened here. And looking at the surgical approach, I believe that also the pes anserina was elevated. One thing that I do for those unicompartmental osteotomies is always to protect the hinge with a wire that comes from lateral to medial. And then by doing that, what I try to do is when I open the wedge, I'm sure that my hinge is not going to break, because when you have a hinge fracture in this particular kind of osteotomy, you're generating another tibial plateau fracture that sometimes may complicate the case, especially in case the fracture extends to the lateral side.
What about the inclination, since there was depression posteriorly, and he shows the, the coronal plane correction, but it's a little bit difficult to tell. It doesn't look like it was necessarily used to correct the posterior slope based on which direction the osteotomy was.
Yeah, I would say if you look at this lateral view specifically that you're showing right now, it's possible to see that the anterior quadrant of the medial plateau looks like leveled. And you see that there is a step off going to posterior medial. And if you do an osteotomy in a different plane than this one that you can see here, you may eventually improve the AP view of the X-ray, but you may not address completely the displacement of the posterior medial quadrant, meaning that you may get an improvement in the MPTA, but you may eventually continue to have a step off in the posterior aspect. So in this particular case, I understand that CT was not available, but I would probably favor to have this patient prone and try to go from posterior medial, trying to see if I could mobilize this posterior medial piece and elevate the posterior medial piece altogether, trying to reproduce the original fracture pattern that the patient had, in case I would be sure that this is the main fracture plane. And this would be a way to do it. When you do that, you have no control to the joint, but also if you go posterior medial and you go in front of the popliteus muscle and you protect the neurovascular bundle, you also don't have to care much about the MCL. Even if your osteotomy is going to extend a little bit to anterior, the MCL is going to be protected because you're not going from the front, you're going from posterior medial.
Okay.
Yeah,
It looks to me,
I would
this is
agree
Rafi.
with Mauricio on that last part there. The one part about going prone, and I would probably be prone on this too, but in my hands, you would give up the opportunity to do anything more than just the articular part. For me, it's way too complicated to try to then adjust like a metaphyseal osteotomy to try to move the tibia.
Yeah.
Agree?
Yeah, I agree 100% with you, Tim.
Yeah.
It's only that my impression looking at those pictures, and I may be wrong because I may not have the entire picture of the case, but I have the impression that it's mostly a posterior medial displacement that I would prefer to address first. And then I could eventually follow what Jim Stenner just mentioned, that you can see what happens restoring the step off and restoring the posterior medial block. And eventually later with an alignment study, if you're still not happy with your final alignment, you may even go back and do something else.
Yeah, it just seems on these type that so often when you do get the joint part reduced, that it fixes the problem. And what I've seen, it's the big exception that you have to go back and do a metaphyseal. So that's why I was kind of leaning that I thought 2 separate stages might make more sense.
Maurizio, if you, or Jim even, if you see, if you do your MRI and then you see some intra-articular soft tissue pathology, meniscal tear, ACL, or some other collateral ligament that may need to be addressed, do you address that at the time of the osteotomy, before the osteotomy, or after the osteotomy?
So I personally would say that I like to know ahead of time, but it's very unlikely that I'm going to address at the same time, or that I'm going to do a very major procedure at the same time. I had situations before when I had varus deformities with significant posterolateral laxity, because they were deformities that have been there for a while, when after and together with the osteotomy to correct the medial column of the tibial plateau, I added a posterolateral reconstruction just to balance the joint. And I believe this combination is very acceptable, because then you restore the mechanical axis and you improve the stability of the posterolateral corner in a joint that's fading in varus. This has been the situation that more commonly I've done together. In terms of ACL, PCL, very likely in situations that are associated with fracture dislocations, and I'm talking about type 4, 5, and 6, it's very common to see PCL, ACL injuries in association. And if this is an intra-articular osteotomy, I'm going to do the ACL, PCL in a second stage. I'm not going to associate an intra-articular osteotomy with PCL and ACL reconstruction, but I leave this open to the panel, because I don't think that there would be a magic recipe for that.
Jim?
For me, if it's something simple like a meniscus, I would do it then, so they don't have a second stage and aren't left with a pain generator. If it's something complicated like a fracture dislocation, I would like to get the bone right and then come back relatively soon, you know, a month or so later, and so that part of the healing can overlap and then go after. But I agree with Mauricio. I think if it's a really complicated ligament situation, there's just too many moving pieces.
Thanks. I think that's sounds sound. So here's what was done. It looks like a tricortical piece of iliac crest placed into the opening of the medial osteotomy. And here is the clinical results. Now 8 years of follow-up, and he used the bone setter app to do new measurements for the case. So I think some of the stuff that we're using to teach everyone, they're starting to do. And so here's his the bone setter looking at the results of the case.
You don't have any lateral view, right, of this knee?
This is just all I have at this point.
Okay, very good.
Looks
I don't
good.
think he took down the MCL when he did this. I think that everything was below it. So that's because he had such an oblique osteotomy. He didn't need to take the MCL down. I think that gives you more.
If you go back to the surgical approach there, or maybe there.
Which one?
The previous one, please, Michael. It looks like to me that you can see the anterior medial aspect of the tibia. And to see this way, you may have to lift the MCL, not sometimes they have to peel off the MCL from the bone, even if you don't cause any kind of tear to the MCL.
Right.
You have to lift it. Otherwise, you're going to cut over the MCL.
Yeah, his wires enter at the distal end of it, so that's probably intentional on his part to keep the osteotomy so distal to start.
Mm-hmm.
Yeah.
Any other final comments?
No, I believe that a very important message here is when you have a unicompartmental malunion like this one, a very good option is an open wedge osteotomy that's going to address this compartment, which is very much inclined to the joint line. So it's a very, very smart decision, and it's a very good alternative for unicompartmental angulations like this one. This has been described very well by René Marty. It's a very reproducible technique, and I would just make sure that as a very good learning point, we have to pay attention to the things that the panel pointed out, like how to preserve the soft tissues structures around, how to be careful with the neurovascular bundle, how not to violate the joint when you do an osteotomy like that in terms of not causing intra-articular displacement to the other compartment. There are many technical details that have to be followed in order to accomplish these results.
Okay.
I'll tell you though, for having limited things to their CT scan, etc. This is a really nice result. 8-year follow-up shows what just getting the mechanical access right, how much that really helps us.
Yeah, and there is very nice literature about this as well, Tim, that says exactly what you said, that the joint, especially in the case of the tibial plateau, may tolerate some step off or some degree of incongruity. What the joint does not tolerate is instability. The problem with that joint lying oblique in that way and with the step off together is that the joint becomes unstable. And now, because the joint has a better containment and because the joint has a better alignment, even with a step off that most likely may still exist in the posterior medial quadrant, this joint is still very functional.
Okay, let's look at another case here. It's kind of ties into this case that we just saw, which was the medial osteotomy, and it's going to tie into our next case. So this is a pre-op case of someone who's now 15, who at the age of 13 was shot in the left knee in a drive-by shooting with a vascular injury and a proximal tibia fracture, who had vascular repairs, fasciotomies, a rotational flap, and repair of the medial plateau. And now they're seeking transfer because they're not able to take care of this. And this is where things are in April of 2018. We can see here, this is an early wound picture as they were doing some of their work here. And this is where it is in September of 2018. So we can see a fairly depressed medial tibial plateau with a small plate on that is not really holding the articular surface as the femoral condyle falls into this defect. Any comments anybody wants to make? This is not the real problem at this time, but why don't we just move forward for so we can get to the problem. So here we are, January of 2019. And in 2019, we can see what looks to be a non-union of the proximal tibia, at least a partial non-union with questionable viability of some of the bone. And they attempted to do an epiphyseodesis to prevent further deformity from occurring. And now they're currently waiting a post-COVID appointment. So this is all per report. They have ongoing issues. You can see the mechanical access, pain with difficulty walking, and a draining sinus from anterior medial with a limb length discrepancy of roughly 1.5 centimeters. Remember that there was a contralateral epiphyseodesis that was done about a little over a year ago. So the question here is, given the patient's age, which is only 15 at this point, how are you going to optimize the joint preservation in context of this and chronically infected intra-articular malunion, non-union? And so the plan first to IND, maybe remove some of the hardware, arthroscopic assessment, and then what to do next. I'll just give you from an infection standpoint my opinions, and then I'll let the faculty give us some of their further ideas, and then this will take us nicely into what we can and can't do. I think with the infection, that this is a chronic infection, chronic osteomyelitis, long-standing. You see hardware and that is not functioning. Screws are backing out. There's probably good purchase in the metadiaphyseal area distally, but I think you need to get all your hardware out. You need to do an adequate debridement, and then you can assess what the bone looks like, as well as what the cartilage looks like, because you'll probably be looking inside and into this large defect. For me, this would be multiple debridements until I have a good clean area. I would pack any of the defect with antibiotic spacer. If you have a large defect, you can put a block spacer in and do a mescalate type technique. If it's smaller or if it's contained that won't need to be bone graft, you can maybe use some resorbable antibiotic beads, some calcium sulfate, which would be an off-label use of that product. But I think the first step is to get the infection cleared before you should even attempt an osteotomy to correct any of the alignment. Does anyone have any other further comments? Would you agree with that, or do you disagree with that as a two-staged operation here?
I
Or
totally,
two stages?
yeah, I totally agree with that. I don't think you can address salvage of cartilage or anything ligament or anything like that until you first get control of the infection. I would, if her draining sinus area and the flap area would allow it, I'd consider using an offloader brace to try and protect the femoral condyle, assuming we may have a problem with the plateau cartilage, to try and keep it as salvageable as possible. But you have to get this infection solved first.
So real quick, one of the questions was, do you, and it pertains to this one as well, like for preoperative evaluation for peri-articular cases, do you try to remove the hardware before getting advanced imaging for planning, or do you just do it and try to use the suppression techniques that are available for MRI or CT scan?
Like get all the hardware out first.
Me too, because we want to lose it anyway.
So for me, when I see this, it's a combination of both. I get all the hardware out because I want to do a debridement anyway. The only imaging I would get prior to doing anything here is a CT scan. And the reason I get a CT scan on every infection is to look for areas of sequestrum where I might want to debride, and so I know what I need to take out. And so all the hardware has to go anyway here. And so take the hardware out and then do any other advanced imaging after that, including an MRI, because I want to know what the extent of the infection is and whether there's bone marrow edema distal to this, or if I can ignore everything else distal to this area.
Yeah, I didn't mean in lieu of infection. I mean in the peri-articular cases. Is anybody automatically removing indwelling hardware to get the advanced imaging? Let's say outside of an infection case. I just wanted to make sure the question got answered.
Well, we saw Keith's case. For those of you that were fortunate enough to see that last week, we did see where Keith had an intra-articular distal femur fracture, and he removed all the hardware because he couldn't figure out exactly what was going on. So it's a great question for the rest of the faculty. I think some people answered it last time, but it's worth repeating if we still have questions.
Yeah, for me, if the hardware is no longer doing a necessary job, I would get rid of it and get better imaging. If you were at a stage where things are still healing, then I would try the suppression techniques. It's variable. Sometimes you can't see anything with those, and sometimes you can.
One valuable aspect of removing hardware and going for a staged procedure would be also to have the opportunity to take some biopsies and to make sure that even if you have the impression that everything is clean and the patient is completely cured from the infection standpoint, you can really confirm with a biopsy by doing that.
So Michael and Mauricio, could you tell the audience how many, when you biopsy these folks, are you taking soft tissue? Are you taking swabs, and what numbers and where?
So for me, with all of the infections that I take, and I mean, I also will biopsy every non-union, especially that's been operated on, to look for infection as a source. And so I do bone, I do soft tissue. You want an odd number because you need to adjudicate if you have one or two or three. So if you have an odd number, you can kind of figure things out. So a minimum of 3, frequently more. I always use tissue samples. I will take swabs as well if it's a place where I can't get tissue from. And I always go in a non-union. I always want tissue directly from inside of the non-union site as well as other areas, and it's always multiple samples because you can get multiple organisms in different areas. Maurizio, do you do anything different?
No, absolutely the same. And I agree with you that revision cases for non-unions, it's absolutely important to have this information.
I want to highlight that too. And it's not that you sample multiple locations and then place it into one auger. You have to take multiple locations and label them separately. And anytime I do a really complex reconstruction where they've had a time of waiting and spacers, I almost always will do just a quick outpatient surgery, a peek and shriek, just to make sure that it's not infected before I go back in with the big implants and bone graft.
So that's a great question. And I've had people say I shouldn't do it, but it sounds like I'm not the only one. If I have a known infection that I treated prior to treating their non-union, I always re-biopsy them to make sure the infection's not gone. Sounds like Raphael, you do the same thing. Do the rest of the faculty do that? Normal markers, no evidence of infection, previous history of infection, but has a spacer or has a non-union still. How many of the faculty are biopsying them before proceeding with the non-union surgery?
I do it.
I have not
everything-
routinely if they have normal markers. Maybe I should though, sounding.
Yeah, I'm the same way. If they have normal markers and my suspicion is low, then I'm not doing that. But educate us, Mike. Should we? Like, how often do you find something there that changes your course?
So let me ask, before I answer that question, so you go in to do your non-union surgery, do you do cultures then?
Yes.
Okay, so what do you do with the positive cultures then?
Suppress them.
Okay. I don't know if I have no evidence that it makes a difference, but I do know that every now and then you get a non-union that was infected that then re-gets infected. And I would argue that it's probably just a continuation of the original infection. So I think for me, in my hands, the best chance of me being able to correct your non-union after an infection is to make sure the infection is gone. And so I re-biopsy them. If you don't, I have friends just like, I mean, you guys are all my good friends and I have no problem, or I hope you are. I have no problem with what you do. It's just that in my hands, this is the way I have addressed it. I don't know if it's right or wrong, but I know it's safe.
It's clearly safe. It's safer. Can I ask a quick question of the panel? Like, is the intra-articular portion of the debridement on this, is everybody opening this? Would people debride the intra-articular portion with a scope on this? Is that a dumb question?
Be awfully tempting to use a scope.
Yeah, I think your best likelihood of maybe salvaging cartilage would be to look with a scope for the cartilage side. And that also, if infection has gotten up into the joint, that's also helpful.
I'm not a daily arthroscopist, so when I use an arthroscope with any kind of depression like this, I put a distractor on, and that gives me all the room I need, especially on the lateral side. But this side's even medial. I would probably distract the joint to really get a good look around and debride when I scope it.
Yeah, I think that's a really good trick because that condyle wants to fall down in that hole. And I do scope a lot, and I still think that's a really good move.
So when you do your arthroscopy, what do you, are you debriding synovium? Is that why you do the arthroscopy?
Yes, and our synovium, scar tissue that is very likely present within the knee, that can be harboring infection. And then also just to get a really good look, do we have an intact articular cartilage layer that is thin and just a little bone below it? Because if so, I'm going to really try to preserve that. Or is it already got big damage, in which case I'm going to not worry about that and really go after all of the area that has infectious involvement. So I would really try to be ginger and get away with things like where you mentioned using the antibiotic spacer. If I had what looked like viable cartilage still intact. And so that's why I'd like to look at it and see. I still may lose it, but I'd try hard.
So I don't really do arthroscopy even once a decade. I use it. The only thing I use the arthroscope for is to put underneath the operating room door if I want to keep it open. But I do an arthrotomy if I have to. You know, even with my acutely infected tibial plateaus, I'll make a counter medial arthrotomy parapatella to make sure I can adequately wash out the knee instead of doing a submeniscal. I don't want to go back through my submeniscal arthrotomy. I'll try to debride it fully, and if I have to do an arthrotomy to debride it, I will. And I'm going to go after as much of the infection as I can, but it's not uncommon for me in a plateau fracture like this that's infected to have a small medial parapatellar arthrotomy to wash out the knee and debride it, as well as to go where the hardware is to debride that. And it's probably just because I'm not very good with the scope and I can do it better by open and looking at it. But I think the arthroscopy, maybe I'll do it with my sports partner more often. There was a question. Go ahead.
So I would like to add that to me, the most important thing in this discussion is the principle on what are we doing. The main goal is not to consider to debride only the area of the tibial fracture, but also to debride the joint. So if you have great skills with arthroscopy, you should use arthroscopy because it may give you a good sense on what's going on in the other two compartments of the joint that may look normal in the x-rays, but they may not be that normal. And the arthroscopy is going to give you a good sense of evaluation. If you're not used to do arthroscopy, it's not a problem to open the joint and do it correctly and make sure that you clean the joint.
Yeah, I was going to say, you want to go to your strength, and I'll bet you anything Mike is way better at doing an arthrotomy and getting the washout than I am. I don't feel like I see very well in there, but then I've gotten really used to using the scope. And then the opposite's probably true, that I'm going to get a much better view with the scope because it's what I'm good at, and I'm not good at the open.
I think that's a great point. There was a question about how to manage defects hardware removal in the face of infection. And it's not really part of this course, but I'll do it real quick, which is you take out anything that's dead, all the bone that's dead, anything else that's not viable needs to come out. You typically, if you leave a defect, you put a cement spacer in. You can use any brand cement. I typically use, try to get higher dose cements in, 2 grams of Vanco, maybe 2.4 of Tobra. The trick is mix the cement first, add the antibiotic afterwards, and wet your hands a little bit when you're playing with the cement, and you'll get all the antibiotic in. You can put the cement in a doughy form. And if you do that, what you want to do is continuously irrigate that cement so that it never gets too hot and burns the bone. And then if you need it as a stabilizer, it actually becomes just like part of the bone. And so that you're able to have stability from your cement spacer. The trick to get it out is not by using osteotomes, because that usually just breaks the bone apart that's around it. And I use an ultra drive or an Oscar or one of the ultrasound things that total joint people use. And I cut my spacers up into a few pieces so that I can take them out gingerly and leave the rest of the very fragile bone in that area. We do have courses on infection, and I recommend that if you really want to know how to do these techniques a little bit better, you join one of our AO North America courses on infection, which you'll see coming up shortly. Brett, you asked for an alignment film. Was this what you were looking for?
Yep.
Okay. So I think we can move ahead. It's 8:45. And so now we've cured the infection, and now what are we going to do? And I think we should move on to the next case, Jim, and you can talk a little bit about, clearly what this is going to need is the medial osteotomy that we just saw, probably to realign. And based on the images here of this CT scan, I'm not too convinced that there's much live cartilage that can be alive on that dead bone.
I agree.
And so I think that's a nice segue into this. And let me give you remote control, okay?
Oh, that'd be great. Okay.
Jim. And so you should have control now over the screen and take us through this case.
Okay. So this is a patient that I think the biggest thing we can learn from this one is kind of thought process and what are the options. So it's a little bit older person, 60-year-old, a surgeon on his feet all day, but really values fitness time and works out 45 to 60 minutes a day, and also has some very mild cardiac issues, but he feels like the working out really keeps that at bay, and arrhythmia, but it feels like keeps it at bay. And so really, really cares about the ability to maintain that. Because the initial easy answer would be, you're 60, you've got a problem, maybe we ought to be going to an arthroplasty. Had a bucket handle lateral meniscus tear 47 years prior as a high school wrestling injury, and had slowly increasing symptoms, but mostly inflection and extension did pretty well, and was able to do all that exercise that we're talking about, just not when squatting down a whole lot, and then tolerated that really quite well. And then right after turning 60, was running on a treadmill, and the medial meniscus tore, and it really imploded like what you see on the picture here. So question then comes, there's another picture of him. You can see there's also some calcium granules in there. There's not been any steroid injections. And so there was some degenerative change, obviously, within that meniscus. So we've got a medial compartment, though, that the cartilage part looks pretty good, despite being 60 and having been pretty active in life. Patella, though, had some grade 4 loss. Trochlea had some very minor loss, but looked pretty good. But then the lateral compartment had grade 4 loss posteriorly and laterally, and a fairly deficient lateral meniscus. So there's the patella, and you can see up in here, we're down to bone on a large portion of this patella. That had been tolerated pretty well, although the patient had been noticing it a little bit more. Here's the trochlea. It's got good cartilage cover and some mild to moderate changes. And then here's that lateral side. And again, this was tolerated well when it was just the lateral side. But you can see we're grade 4 on both the femur and the tibia, and a meniscus that is definitely a long way from normal. So this is kind of the scenario. There's again, your medial meniscus tear as well, your lateral compartment. And then the first thing that was done was some surgeons went in and tried to see what they could do with that medial side, and it ended up a subtotal medial meniscectomy. So now the question is, what do you do? What's the thought process? We've got 3 compartments involved, and a 60-year-old who really doesn't want a total knee, but that doesn't mean that we let that person have what they want, and got these standing x-rays. So I'd be curious from the panel what they think of this and what the thought processes are about what's a reasonable way to proceed.
My comment, I'll just make a comment, sorry I'm late. I don't do much sports, and I think that's probably a weakness. So I usually don't even get an MRI with these and wouldn't have the whole history of the meniscal pathology. But with that said, with a clinical exam that would suggest some lateral joint line pain by realigning the patient, my ignorance would push me to an osteotomy, and the patient may do okay. That's probably a very immature and I don't know, macro way of thinking of it, but those are just my thoughts. Not having really any training or experience in arthroscopy and meniscal pathology.
Sure. And I think it's a reasonable approach, though, and it might make a huge difference all by itself. Any other thoughts? If not, I know we're running short on time and I can just roll through, but.
We're okay. We got about 10 minutes. Maurizio,
Okay.
What are you thinking? What are your thoughts?
Yeah. Thanks. I would say it's a tricompartmental pathology, as has been mentioned, with valgus alignment. There is a decrease in the lateral distal femur angle. And most of the pathology is in the lateral compartment, but now we have a medial compartment that has a medial meniscus deficiency. So in case we are going to correct this lower extremity and correct the alignment, one has to be very careful not to overcorrect this joint, because you cannot overload the medial compartment that currently does not have a great meniscus. And in case you're going to do something, you have to consider how to address the three compartments and do something for each one of those. And then you have options for cartilage and things like that. But most commonly, if you want to address the alignment, you should be careful not to overcorrect it.
And I think, other potentials when you have good cartilage medially, and people will argue about patellofemoral joint, obviously you could tell this person, sorry, you're getting old, dude. It's a total joint for you, and see how they responded. You could consider a lateral unicondylar, and it's true you don't have a functioning medial meniscus right now, but you do have good cartilage over there. It was really in good condition, and so that's something to consider. Or there are biologic opportunities now that potentially allow you to do a mixture of techniques. Anybody else have any thoughts before we move on?
Anything
One more.
biological is going to need a horizontal joint line. And so even if you correct the femur and you say his MPTA is normal, but it's going to be loading that medial side unless you do something to level the entire joint.
Right. So I agree with that. I think you've got to address the joint malalignment no matter what. This kind of shows what I was just mentioning, some of the different options, or again, I think a combination of these options.
Does anyone use valgus distal femur correction to realign or decompress the patellofemoral joints? And if so, would that also help the anterior knee pain and the lateral knee pain?
I would say when correcting those patients, in this particular case with more advanced arthritis in the lateral compartment, patellofemoral compartment, no doubt that correcting the alignment is going to really contribute to the two compartments, just by improving the tracking of the patellofemoral joint.
Yeah, and I would also say that this joint is going down the tubes if left alone with this valgus that's happening, separate from that medial meniscus. And so I think it was going downhill, but then it was kind of a final nail in a coffin that something needed to be done. And you can look at a combination of these things, but I do think the osteotomy is a very important component of the something that needs to be done. Even if, like some of the cases we've seen, you're doing an osteotomy to set up for a really good total joint, or for a lateral uni, or some of the different, again, biologic techniques that are becoming more and more available. And we've kind of been on the forefront of that because of some researchers at Missouri. And so we ended up electing to do a combination of techniques, but this is the live viable articular cartilage in this picture below of that patella. And then this is the meniscus that was being grabbed. And this is, again, that's a live meniscus, not a frozen one. Most people that transplant do a frozen one. And those were both combined with then. And we also think there was a lot presented at the Orthopedic Research Society this year that the fat pad, when you start to get into chronic issues with the knee, starts to become a generator of some of the things that help start then destroying the knee. So there was a pretty decent resection of fat pad as well. And so then here's what happened. The meniscus was harvested and placed in. And then here's the patella that was there. It was cut off, just the articular surface with the bone left. And then this is what was cut off. This is what was put in. Use some bone marrow aspirate concentrate from the recipient onto that donor bone after washing out all the cells. The tissue bank already washes out cells and then washed out again intraoperatively. And then there's the articular surface of the patella put back on. So the concept here was, let's address the two areas that are really pretty good. The medial side had really good cartilage. So if we could get a meniscus back, that could do well for a long time. And then the patella, that's not, as we keep developing these techniques, that's a relatively easy transplant and with a really high healing rate. However, if now we have the ability to do the same thing on the lateral side and replace all of it, but that becomes a huge operation in a 60-year-old. So we felt that wasn't the way to go. So we combined it with this closing wedge osteotomy. Excuse me. With this closing wedge osteotomy. Sorry, I'm trying to get this to shut off. I apologize. And I lost the picture in here of the talk. But anyway, we did the closing wedge osteotomy, and so we combined biologic with the reconstructive.
Jim,
Yes.
Jim, can you comment on blood supply to the patella and resection of the fat pad? Any issues there?
I don't think from the fat pad there's a substantial issue, or if there is, we haven't perceived it as harming the healing of that. It's a really big cancellous surface, and the two easiest areas we've had to get to heal are the trochlea and the patella, and they really have healed real well.
So Jim, there's a question here: is how do you fix the patella cartilage back into the patella?
It's done with bioabsorbable K-wires, and a series of 4 of them at least. And that it seems a little flimsy, but boy, it holds. Again, it's 2 really rough cancellous surfaces that want to stay together, and so that the stability of that has not been an issue.
And the ones that are used have the same compression strength as a 2-4 cortical screw.
Hey, Jim. So beautiful case, but I'd kind of like to ask the panel, as a bit of a dinosaur, I guess, because, one, I do arthroscopy less than Sirkin does, which, and
Mine was in residency.
And 2, I'm almost this guy's age. I'm 58, so it's worrisome when you're saying 60 is old. But
well, some people say that. I don't, because I'm around that age as well.
Yeah, but my question is, to what extent should we be basing our decisions for osteotomy or not osteotomy and some of these things on using the arthroscopy? Because in the past, it never really was part of the decision-making process. And when you go back to your standing alignment view, your articular, on the standing alignment view, the joint surface looks reasonable. And I know based on your arthroscopy, it's not so great, but there's still a joint space there. And so in my hands, I'm probably much more like Mitch, because I wouldn't have, I don't have the skill to go ahead and evaluate this. And just for the participants that are out there, to what extent should we be basing our decisions on arthroscopy and how much, like in the past, where we would look at the standing alignment view and say, let's get the mechanical axis right.
Well, and one thing I'll say, I don't know the answer to your question of how much we should use the arthroscopy, but that was a close-up of the back of the tibial plateau and the flexed femoral condyle. When you go into full extension and you're looking more at the front, it's got decent cartilage, and that's why the person was handling it okay until they then blew up the other side, and then things were starting to go downhill fast. So that's why I think the osteotomy is a really viable option here, because the back part of that joint is not good, but the front part and the joint in full extension is actually not horrible. It is with a non-functioning lateral meniscus, but he'd handled that for 47 years.
Yeah.
I would like to add a comment to this one. It's a great case. What I like very much in this particular case is that all the joint orientation angles were restored to normal. You can see that the joint convergence angle is not completely normal. It's slightly open medial now. And the reason is because of the medial meniscal transplant that ended up adding a little bit of space to the medial compartment. And in this case, the final alignment is 1.5 degrees of valgus, most likely related to the opening of the medial compartment that could not be planned in this case because we never know how much you're going to open the medial compartment. The problem here is how to be precise when you combine an intra-articular procedure with an extra-articular procedure in order to come up with final angles. And in this case, it was a medial closing wedge, which is a great procedure in terms of granting a great broad surface and a very fast healing.
So here are our x-rays, just a short time later with a nice result.
And what I would like to say, if you go back, see how fast the patella starts to heal. If you compare April 2nd to May 8th, you'll see that the fracture line is disappearing and the osteochondral allograft is incorporated. And you see that the osteotomy also has no displacement in the lateral projection. You cannot see the osteotomy there. It's a biplanar cut. You cannot see it. And it seems that the hinge is protected as well, which means that it could be a case where the healing should be very fast.
Okay, I think we're just about out of time now. I think we answered most of the questions. Remember, you can access the recordings with YouTube at the AO Trauma North America YouTube channel. We've added a lot of stuff there. I encourage you to check it out. There's the videos that we promised we'd put up on how to put blade plates in, as well as all of the week's last 8 weeks worth of videos as well. Remember, this Saturday coming up, this will be our final lecture series. We'll have dealing with bone loss, and Mitch will go over some bone transport cases. We'll have Sean Nork go over some malunion and mathematically directed osteotomies. Tim's going to show us how to do some distal extra-articular deformities about the ankle. And then we're going to show some intra-articular cases with all of the faculty. You have an exciting group of faculty there, and I think it will be quite enjoyable. I want to thank everyone once again for participating with us, and thank you for your attention.